infants. Now, coming to the IUGR babies are near term babies who are born with a birth weight less than 2,500 grams. They do have adequate reflexes and stimulate lactogenesis. But they are at some risk of hypoglycemia because of the poor energy stores and hypothermia because of the lack of brown fat. Then they are vigorous at birth. They can latch on to the breast good and suck very well. Monitoring the but still they would require monitoring till the complete feed establishment and for the follow-up catch-up growth. So as I was mentioning about the nutritional requirements, so preterm babies, late preterm babies and term babies, the targeted nutrient requirement is depicted in this table, and we can see that the composition of the breast milk, see, nearly what is the requirement of the term baby is total exactly almost double for what the extreme preterm or extremely low birth weight babies require. That makes it difficult for breast milk alone to meet the nutritional need of these babies. Now, what is the feeding option for all these babies? As we were discussing, breastfeed, mother's own milk is the first choice. Then direct breastfeeding is not possible. Then attempting for direct breastfeeding along with the express feed of the mother's own milk as a top-up. Then later, the breast milk or the other milk which can be mixed or the donor milk can be given. If absolute not availability makes it for the formula feeds. Then breastfeeding in preterm babies is considered as the best form of nutrition for preterm infants in the gut microbial community. This is what the latest researchers are suggesting of this. Apart from this, as I was mentioning, these babies would be having low muscle tone. They cannot maintain the posture properly. So it is from the mother's side, the holding the baby, training the mother for the proper positioning, proper support while feeding, and the proper swaddling of the baby gives a better tone and a better balance for the mother to improve the feeding outcomes in the this low birth weight babies. And mother has to be trained on identifying the hunger cues to start the feeds. Because these preterm babies are the voracious and the irritable babies, once they are too much hungry, they refuse to latch onto the breast and their lactation becomes ineffective. So the hunger cues has to be understood by the mother, and mother has to initiate the early feed so that baby gets a little time to correctly latch onto the breast and to continue the feed. And slow rhythmic movements during the care of the babies would also improve the better lactational outcomes in these babies. Now, coming to the recommended fluid requirement for these babies, you can just see one has to, on the day one, the baby would require around 60 ml per kg per day, and that has to transit to around 150 to 160 ml at the end of the week. So, from a few drops or few ml of colostrum to the mother has to transit to this. But if there is no proper the stimulation, this is auto failure and the baby would be ending up in the early malnutrition, right? And that may continue throughout the first year, and the babies remain fall short of this the nutrient deficit if the feeding is not taken care properly. Now, what are the goals of the feeding of these babies? Ensure the adequate nutrition, that's the first goal, and protecting and sustaining the maternal milk supply, that is again for a better lactational outcome and infant and maternal health benefits. We all know that yesterday, madam was discussing about the benefits of the breast milk to the mother as well as the baby. Now, these are the supplements. So far, we were just discussing regarding the breastfeeding in these low birth weight babies, how important and what has to be done. Now, as we were also discussing, the breast milk alone may not be able to supply all the nutrients which the baby would require. Especially so for very low birth weight babies who are less than 1500 grams, they might require an additional supplementation with the calcium, phosphorus, vitamin D and iron. And the recommended dietary supplementations are given in the table. And it is always better how long to give this supplementation for calcium till the baby reaches the term gestation, and of course calcium and phosphorus, and vitamin D is advised to be given till 6 months of age, and iron supplementation to start at 2 weeks of gestation, 2 weeks of postpartum age, and to be continued till the 6 months of age. As we know that the hepatic stores of all these are very, very less in very low birth weight or the preterm babies. For other low birth weight babies who weigh between 1500 to 2500 grams, so the recommended dietary allowance for vitamin D is 400 international unit, right? And that has to be continued till 6 months of age. And iron is about 2 to 3 milligram per kg per day, to be started at around 6 to 8 weeks of age and continue till 6 months of age. Now, how to improve and sustain the lactation? As we were discussing, early initiation of the breast milk is the first stimulation for the type 2 lactation. That is the stage where mother has to increase the prolactin receptors and the breast milk secreting glands. So early initiation of the breast milk may be a theoretical one when we speak of preterm and low birth weight babies, and also late preterm babies, because of their ineffective latching and poor neuromuscular tone. Now, what is the alternative for this? Early initiation of the breast milk, pumping. So every hospital should have been equipped with a hospital grade breast milk pumps. And if the mother is taught to pump the breast milk right from the day one, and frequently once in every 2 hours or 3 hours, it is the better. As much as the same stimulation can be given, so that the lactation will be uninterruptedly happening in the next few days when baby is ready to feed. And the expressed milk can be used as a trophic feeds for these babies, which is considered as the best form of mother's own milk. The use of test weighing, then how to make it sure that the baby is getting the milk. So it was like, previously there was some, I think we'll discuss it later also. Then test weighing and minimizing the use of pacifiers should be taken care for the better establishment of the exclusive breastfeeding. Improve the NICU visits of the mother as well as father, and encourage the kangaroo care, which will sustain the lactation in the immediate postnatal period. Then the lady has to taught to encourage the non-nutritive sucking for the babies. As we know that baby, though is not having enough neuromotor tone, but they can be allowed to suck at the empty breast. Mother is asked to express the milk, and she is advised to continue the feeding of the baby, latching the baby onto the breast. So that is the best pacifier for the baby, and that also improves the oromotor tone of the baby for the better outcome later. Now, these are some of the growth monitoring charts which are published in the standard journals. They say that how the nutritional quality of the baby at birth will go down if the feeding is not taken care. And they may remain the poor throughout their nutrition in the coming days. And if we are able to manage these energy gaps, then the babies would be following the normal growth pattern. Now there are some role. So there were some controversies like, babies will be fed better if they are given with the express breast milk through the tubes and all. Of course, that is true because the babies would be getting, you will have the calculated quantity to be given to the baby, and the babies would have better weight gain. But there are some role of smell and taste also in the stimulation of the lactation, right? And the mother as well as the baby would have a better the bonding, nutrition, and the attachment once they are directly exposed to the smell and the taste of the breast milk. Now, as long as the baby is on the tube feed or this one, mother is advised to stimulate the oromotor tone and the suckling of the baby, either by introducing the finger while the baby is fed with the tube, or sometimes the baby is attached with this one in the periods of relactation also. The baby would be attached with a feeding tube to the mother's breast, and the expressed breast milk will be trickling down through the tube, and the baby would be sucking at the nipple. So that will serve the purpose of both stimulating the breast tissue as well as the nutrition of the baby. Now, this adequacy of feed could be assessed using some of the standard assessment tools like latch of the Bristol breastfeeding charts are available. There, or else one can accurately measure the weight gain, and one has to keep a target of 20 gram per day. And monitoring the blood values, especially the blood glucose for the initial few days, 2 to 3 days, especially in the late preterm and IUGR babies, is essential to improve their feed tolerance and also study their feed and behaviors. Then test weighing, as I was telling, as soon as you feed with one quantity of feed and the baby is weighed and noted down with say for example, the baby is given 30 ml of feed and the 30 grams, you are expected to increase the baby's weight. So, but that may not be a very practical one with all the preterm babies. So one can definitely use the other methods of assessing the adequacy of the feed. Apart from this, we also know that the baby should have a progressive weight gain. It should pass 4 to 5 stools at least per day, and 8 to 10 the urinary output should be there. That would confirm the adequacy of the breastfeed in the preterm babies. If inadequate, then think of introducing the alternate feeding methods, either with a Paladay or alternate direct breastfeeding method, as we were discussing just before, or else express breastfeed till the inadequate one can think of the formula feeds for short term, and then later one can establish the direct breastfeeding for the babies. And growth plotting is another way of noting the baby's catch-up growths. Now, so once we have to monitor all these things, we have to think that the babies has to be under the regular follow-up. Of course, till the NSU stay, they will be under follow-up once they are discharged. So what should be the discharge policy also we have to think. Especially preterm, very low birth weight babies who are having the standard guidelines, they will be watched for. This is the late preterm babies or the IUGR babies. One has to ensure before discharging them that they have adequate latching, and hence one may think of delaying their discharge maybe by 3 to 4 days postpartum. Then you always ask them to visit the hospital for at least 3 to 4 weeks every week, so that the feeding and the weight gain could be monitored for the baby. Then proper feeding education to the mother is very essential regarding the posture, latching, and the duration of the feed and all is very important. Now moving on to the Ayurveda perspectives, there's nothing much for me to tell about the preterm baby feeding, but the one sentence which is the base, which makes the base of all these efforts is Madhureva Pibet Stanyam. That means most of the situations, it is always better to feed the mother's fresh milk to the baby. Tadyalam, that is everything for bringing up the proper growth of the baby. Stanya dhatra ubekare, in case it is not available or insufficient, dhatri milk has to be taken. Tad asampadi vatsale. So if both these are not available, then only the alternate feeding methods like, animal milk and all is mentioned in our classics. But because of nowadays, increased the care of neonates, reduced the number of the babies, increased the identification of the intolerance, feed intolerance, all this makes it is little sensitive to introduce animal milk in the initial weeks of life. Once you are sure that the baby is gaining enough weight, has reached the near term, and baby is not having any feed intolerance, then it is always prudent to introduce the animal milk. And we also know that there is a homogenizing method also mentioned in Ayurveda, that is treating the animal milk with a stiradve or a laghupanchamula or musta. So that makes it more homogenized with the addition of little 1 scoop of the sugar, 1 spoon of sugar to the 100 ml of milk. It makes it more homogenized for the baby for better absorption. And we also know that there is a concept of garbhashosha, and the treatment for the same is mentioned in Charaka Samhita, says that garbhe shushkeshu vatena balanam cha ati shushatam. So the weight reduction in the weight or the intrauterine growth restriction is looked in terms of garbhashosha. And for that, Sita, Kashmarya, Madhukair, Hitam, Uttapane, Paikshira Pakas have been mentioned to improve the weight of these babies. If we are able to identify, because it's nowadays it's possible because of the better antenatal follow-ups, then one can try to adopt these things. And we effectively practice Vidaryadikruta in our clinical setup. And they've also mentioned like Sarva Vata Vikaranam, Thailand, Anyanyatah Shruno, Chatushprayogani, Ayushya Balavarnakarani. So Thaila can be used for the Chatushprayoga. Internal, external procedures can also be done using the Thaila. This may be the concept that we initiate the Apenga for the babies who are stable right from the day one, and it will be continued, and we ask the mother to continue this for at least for the next 6 months for the babies at their home. And frequently we use Balashwagandha Lakshadi Taila, or sometimes Eshtimuru Taila is also used for doing Abhenga for these babies. Now there are some 2 or 3 case reports which the late preterm babies. Of course, we have the basic NICU setup in our hospital, where late preterm babies we are taking care, and the sick babies, definitely we don't have the manpower to manage all these things, will be referred to the higher centers. So 14-day-old baby was brought with a history of, it was a late preterm baby delivered in our hospital with a weight loss. It was brought on the 14th day, and baby was 2.4 kilos at birth, and it was brought with a admitted on the 14th day with a 1.8 kg weight. And this baby, the reason could be, the mother was initially, along with the breast milk, to meet the nutritional need, we had put the baby on the formula feed. But mother suddenly stopped the formula feed without thinking. And the breast milk supply was not enough, and the baby was not feeding well. Latching was not proper, and the result was the baby was brought back with a weight loss. The baby was admitted in the hospital. So as a rule, we started with the we initially asked the mother to express the breast milk just to assess how much is the lactation, and the additional deficit was the baby was continued with the direct breastfeeding. Additional deficit was given in the form of formula feeds. And we did add Vidaradhigruta, 5 drops with every feed for the baby. And the outcome was very better. And the baby was discharged at the end of the week with a 2.45 kg with the makeup of the birth weight. And the meantime, baby mother was trained regarding how to feed the baby. And along with this, Abhyanga and Shiropuchi was continued. This was another case which was treated with a similar principle. It was a preterm baby delivered elsewhere. On the 14th day, 16th day, they visited us. The baby had 1.4 kg at the birth, and they visited on the 16th day with the same weight. The baby was not on any additional feeds, or the baby was not given with any other supplements, not even the calcium and vitamin D. We just started with our regular protocol of management. Mother was added with the Stanyavardhana medicines also. And as a result, within next 2 weeks, the baby had around 1.5 kilo weight, and at the end of 1 month follow-up, baby was almost had gained 500 to 600 grams of weight. That was an encouraging thing for us, that our medicine could also work. But I would not say it is all everything. We should have a continuous monitoring. It becomes sin on our part if we do not identify the calorie and the protein deficits for these babies and to attempt to improve their weight gain. Otherwise, in the lifelong, they might have a lesser IQ, poor neurodevelopmental outcomes, so the poor the immunity. So these all could be better managed by identifying these deficits in the baby. With this, I think I would like to stop. Thank you for the patience hearing, and thank you for the opportunity.